Welcome to Pharmacology Outline channel. In this video, we will explore most common respiratory diseases including bronchial asthma, chronic obstructive pulmonary disease, allergic rhinitis, and cough. This information is vital for healthcare students and professionals aiming to understand the pathophysiology and modern treatment approaches for these impactful conditions. Before we dive into the individual disorders, it's important to build a foundational understanding of key biochemical and physiological players. One must understand the roles of substances like arachidonic acid derivatives, histamine, and the broader processes of inflammation and allergy. The human body communicates internally using various chemical messengers. These can be categorized into three major groups. First, neurotransmitters. These are chemical signals released from neurons. They act either on other neurons or directly on target organs to produce immediate effects. An example is acetylcholine acting at the neuromuscular junction. Second, hormones. These are produced by endocrine glands and travel through the bloodstream to reach distant organs. Think of insulin, which is secreted by the pancreas and regulates glucose levels across multiple tissues. Third, autocoids, also known as local hormones, are released by specific cells, such as mast cells or enterochromaffin cells, and act only on nearby cells. Their effects are localized, short-lived, and play crucial roles in inflammation and allergy. In the context of respiratory diseases, several types of autocoids and immune mediators are particularly significant. These include amino acid derivatives like histamine and serotonin, which contribute to vasodilation and bronchoconstriction. Fatty acid derivatives known as eicosanoids, such as prostaglandins, thromboxanes, and leukotrienes, which influence bronchial tone, vascular permeability, and inflammatory cell recruitment. Cytokines, such as tumor necrosis factor alpha and platelet activating factor, as well as interleukins like interleukin 1 through interleukin 35, which regulate immune and inflammatory responses. These substances play pivotal roles in mediating symptoms like bronchospasm, mucus hypersecretion, and airway inflammation. Here, arachidonic acid acts as a key substrate in this pathway and splits into two main metabolic routes. 1. Cyclooxygenase pathway, COX1, COX2. On the left side, the cyclooxygenase pathway converts arachidonic acid to prostaglandin G2 and then to prostaglandin H2. These prostaglandins can further give rise to prostaglandins, which cause pain and inflammation, thromboxane, which causes platelet aggregation, prostacyclin, with other vascular effects. 2. 5-lipoxygenase pathway. On the right side, the 5-lipoxygenase pathway converts arachidonic acid to leukotrienes. Leukotrienes are responsible for causing bronchoconstriction, asthma attacks, and smooth muscle contraction. To further understand respiratory disorders, we must consider the immune system's contribution. Immunity can be broadly divided into innate immunity and adaptive immunity. Innate immunity, which offers immediate but nonspecific defense mechanisms like mucociliary clearance and phagocytosis. Adaptive immunity, which includes more specific responses involving B and T lymphocytes. A key player in allergic respiratory disorders is immunoglobulin E. This antibody type binds to allergens and triggers mast cells to release histamine and other mediators. Naive T cells are also central to immune regulation, differentiating into various subsets like T helper 1 and T helper 2 cells, which influence the inflammatory pathways involved in asthma and allergic rhinitis. Now that we have covered the foundational physiology, we will move on to the clinical content. In this presentation, we'll cover four major categories of respiratory disorders. 1. Bronchial asthma, a chronic inflammatory disease with reversible airway obstruction. 2. Chronic obstructive pulmonary disease, or COPD, a progressive condition characterized by persistent airflow limitation. 3. Allergic rhinitis, an allergic inflammation of the nasal mucosa. For cough, a protective reflex that may be dry or productive, acute or chronic. Each of these conditions involves distinct yet sometimes overlapping pathophysiological processes and therapeutic needs. Let's begin with asthma. Asthma is a chronic disease of the airways that can significantly impact quality of life and requires lifelong management. The Global Initiative for Asthma defines asthma as a chronic inflammatory disorder of the airways. It is characterized by recurrent episodes of wheezing, breathlessness, chest tightness, and coughing, particularly occurring at night or in the early morning, along with variable and often reversible airflow limitation. Asthma is clinically defined by a triad of symptoms: paroxysmal wheezing, dyspnea or shortness of breath, persistent or intermittent cough. Airway hyperresponsiveness is a hallmark, where even minor irritants can provoke strong bronchospastic reactions. Asthma can be classified based on the trigger factors into extrinsic asthma, also called allergic asthma, which is the most common form. It's triggered by allergens such as pollen, dust mites, or animal dander. The immune system overreacts, releasing immunoglobulin E antibodies that cause inflammation and symptoms. Intrinsic asthma, or non-allergic asthma, is not related to allergens. It's often triggered by factors such as cold air, emotional stress, exercise, or respiratory infections. Exercise-induced asthma involves airway narrowing during or after vigorous physical activity, and typically responds well to bronchodilators. Each type may require tailored approaches to management. The hygiene hypothesis provides an explanation for the rising prevalence of allergic asthma in developed countries. It suggests that living in extremely clean environments during early life limits exposure to common infectious microbes. As a result, the immune system is not properly trained to differentiate between harmful and harmless stimuli, leading to an increased risk of developing allergies. This hypothesis also describes the immune balance between helper 1 and T helper 2 cells. In environments with fewer microbial exposures, there is reduced stimulation of T helper 1 cells. To compensate, the immune system shifts toward T helper 2 dominance, which promotes the production of immunoglobulin E, and is linked with allergic diseases such as asthma. Thus, limited early exposure to pathogens may inadvertently increase susceptibility to allergic inflammation. Here's how it works. Infections stimulate T helper 1 cells, which release cytokines that balance the immune system. But in environments where exposure to germs is limited, T helper 1 activity is reduced, and the immune system compensates by increasing T helper 2 activity. This T helper 2 dominance leads to immunoglobulin E, overproduction, mast cell activation, and allergic inflammation, hallmarks of allergic asthma. To summarize the definition of asthma more clinically, asthma is a chronic inflammatory disease of the airways. It is characterized by airway hyperresponsiveness, where even minor triggers cause significant bronchoconstriction. Clinically, asthma is manifested by a triad of symptoms: wheezing, dyspnea, and cough. An asthmatic attack occurs in two main phases: acute early phase and late phase response. The acute early phase response happens within minutes of allergen exposure. It results in bronchospasm, leading to wheezing and shortness of breath. The late phase response occurs 4 to 12 hours later, often at night. During this phase, the release of chemotaxins like leukotrienes attracts inflammatory cells. This causes vasodilation, mucosal edema, mucus secretion, and persistent bronchospasm. Shedding of the airway epithelium also exposes nerve endings, increasing bronchial hyperresponsiveness to even weak stimuli for days or weeks after the attack. Assessing asthma severity relies on both symptoms and objective measurements. Two key tools are the peak flow meter, which measures the fastest speed of exhalation. A decrease in peak flow suggests worsening airway obstruction. Spirometry, the most common pulmonary function test, measures both the volume and flow rate of air. It helps diagnose asthma and differentiates it from other lung conditions like COPD or pulmonary fibrosis.
Classification of asthma severity ranges from intermittent to mild persistent, moderate persistent, and severe persistent asthma. This classification guides the stepwise approach to asthma treatment. There are three strategic approaches in asthma therapy. 1. Relievers. These are fast-acting bronchodilators like short-acting beta-2 agonist, used during acute bronchoconstriction. 2. Controllers. These include anti-inflammatory agents such as inhaled corticosteroids and long-acting bronchodilators to prevent symptoms. 3. Prophylactic agents, like leukotriene receptor antagonists, which prevent both bronchoconstriction and inflammation.
When treating asthma, medications are broadly divided into two major categories: bronchodilators and anti-inflammatory agents, alongside oxygen supplementation for patients with low partial pressure of oxygen, or low oxygen partial pressure.
Let's start with bronchodilators, which are used to relax airway smooth muscle and improve airflow.
Among these, we have the beta-2 agonists, which are further subdivided into short-acting beta-2 agonists, used for quick relief during acute asthma attacks, and long-acting beta-2 agonists, used for maintenance therapy in chronic asthma. Other bronchodilators include methylxanthines, such as theophylline, and muscarinic antagonists, which block cholinergic receptors to prevent bronchoconstriction.
Next, we move to the anti-inflammatory agents, which are critical in controlling the underlying inflammation in asthma.
A key group here is the corticosteroids, available in two forms:
inhaled corticosteroids, or ICS, which are the mainstay of long-term asthma control,
and oral corticosteroids, which are typically reserved for severe or uncontrolled asthma.
Additional anti-inflammatory options include mast cell degranulation inhibitor, monoclonal antibodies, leukotriene modifiers that include lipoxygenase inhibitors, which block the synthesis of leukotrienes, and leukotriene receptor blockers, which prevent leukotrienes from binding to their receptors.
Altogether, these therapies are selected based on asthma severity, frequency of symptoms, and patient response to treatment, offering a stepwise and personalized approach to asthma management.
The first-line bronchodilators used in asthma management are selective beta-2 adrenergic agonists.
They bind to beta-2 receptors on bronchial smooth muscle, increase cyclic AMP, and cause smooth muscle relaxation, leading to bronchodilation regardless of the underlying trigger.
These agonists are classified by duration and route. Inhaled short-acting beta-2 agonists, SABA, like salbutamol and terbutaline, are used as quick relievers during acute attacks.
Their onset is within 5 to 15 minutes, with effects lasting about 3 to 4 hours. Inhaled long-acting beta-2 agonists, LABA, like salmeterol and formoterol, are used for long-term control but not for acute relief.
Their action lasts for about 12 hours and is best used in combination with corticosteroids. Oral, tablet or syrup add-on therapy to control attacks, less common. Side effects: tolerance, downregulation of receptors, palpitation, tachycardia, and tremors with systemic use. Let's list key agents. Quick relievers: short-acting beta agonist salbutamol, terbutaline, albuterol. Long-term controllers: long-acting beta agonist salmeterol, formoterol. Frequent use of short-acting beta agonist indicates poor asthma control and the need to step up therapy. Long-acting beta agonists should never be used alone due to risk of exacerbation. They must be combined with inhaled corticosteroids. Inhalation is the preferred route for asthma medications due to localized action and minimal systemic side effects. Delivery methods include 1. Metered dose inhaler, require good patient coordination. 2. Dry powder inhalers, easier to use, don't require coordination. 3. Nebulizers, deliver high doses without the need for coordination, especially useful in severe attacks or pediatric patients. Proper inhaler technique is essential for medication effectiveness, as improper technique can drastically reduce drug delivery. Inhaled corticosteroids are considered the backbone of asthma therapy. They reduce airway inflammation by suppressing inflammatory cells and inhibiting leukotriene release. This leads to reduced mucosal edema and improved airway responsiveness. Inhaled corticosteroids also upregulate beta-2 receptors, making bronchodilators more effective. Inhaled corticosteroids are most effective when inhaled, allowing local action in the lungs with minimal systemic exposure. Common inhaled corticosteroids agents include beclomethasone, budesonide, cyclesonide, fluticasone. These drugs should be used daily as maintenance, not as rescue therapy. Systemic corticosteroids, either oral or injectable, are reserved for severe asthma or status asthmaticus. Improper use of inhalers often leads to drug deposition in the mouth and throat, increasing the risk of oropharyngeal candidiasis, fungal infection, hoarseness due to vocal cord irritation. To minimize these risks, patients should rinse their mouths after each inhaled corticosteroids dose. Spacers can also help reduce deposition and improve delivery. For severe asthma cases, oral corticosteroids like prednisone and triamcinolone are used. They are typically prescribed as burst doses, for example, 40 to 60 mg per day for 3 to 10 days, then tapered off gradually. In status asthmaticus, an emergency condition, intravenous methylprednisolone is administered. Note, systemic corticosteroids have more side effects than inhaled corticosteroids, so they are used only when necessary. Leukotriene modifiers target the inflammatory pathway in asthma. Montelukast, a leukotriene receptor antagonist, blocks the action of leukotrienes, reducing bronchospasm and inflammation. Zilotin, a 5-lipoxygenase inhibitor, blocks leukotriene synthesis at its source. These drugs are given orally, well tolerated, and used as add-on therapy in mild to moderate persistent asthma, especially if inhaled corticosteroids are not sufficient alone. Leukotriene antagonists are not effective for acute asthma attacks. Are useful for prophylaxis, particularly in aspirin-sensitive asthma. Offer good control in children and patients preferring oral medications. Because of their good safety profile, they are a popular add-on therapy to reduce the dose of corticosteroids needed. Antimuscarinics, like ipratropium, block M3 receptors on bronchial smooth muscle, preventing vagal-mediated bronchoconstriction. Though less effective than beta-2 agonists in asthma, they are useful in patients with COPD, or those with asthma triggered by irritants. Ipratropium is delivered by inhalation and is typically used as add-on therapy, not as a standalone treatment. Xanthines, such as theophylline and aminophylline, are older bronchodilators. They work by inhibiting phosphodiesterase leads to an increasing of cyclic AMP that cause bronchodilation. Blocking adenosine receptors leads to a reduction of calcium, so bronchodilation occurs. They are taken orally but are now rarely used due to narrow therapeutic index and serious side effects, such as seizures, especially in children, fatal arrhythmias, gastroesophageal reflux. Leukotriene antagonists are preferred over xanthines as add-on therapy today. Omalizumab is a recombinant humanized monoclonal antibody that targets the Fc portion of immunoglobulin E antibodies. By binding circulating immunoglobulin E, omalizumab prevents immunoglobulin E from attaching to mast cells and basophils, thus blocking the allergic cascade. It's indicated for moderate to severe allergic asthma that is not controlled with corticosteroids. This biologic is administered subcutaneously and has shown to significantly reduce asthma exacerbations. However, its high cost limits widespread use, and it is typically reserved for severe cases after standard treatments have failed. Asthma is best managed using a stepwise approach, guided by symptom severity and control. The steps generally include: Step 1, use of short-acting beta-2 agonist is needed. Step 2, add low-dose inhaled corticosteroids. Step 3, combine inhaled corticosteroids with long-acting beta-2 agonist, or consider leukotriene receptor antagonist. Step 4. Increase inhaled corticosteroids dose or add additional controllers. Step 5. Refer to a specialist, consider oral corticosteroids or biologics like omalizumab. Patients are stepped up when symptoms worsen and stepped down when good control is maintained for at least 3 months. Now shifting focus to chronic obstructive pulmonary disease, or COPD. According to the Global Initiative for Chronic Obstructive Lung Disease, COPD is defined as a common, preventable, and treatable disease characterized by persistent, usually progressive airflow limitation, due to a chronic inflammatory response to noxious particles or gases. Unlike asthma, the airflow obstruction in COPD is largely irreversible, and symptoms slowly progress over time. The leading cause of COPD is chronic exposure to harmful particles or gases, especially cigarette smoke. Other contributing factors include occupational dust and chemicals, air pollution, genetic predisposition, such as alpha-1 antitrypsin deficiency. COPD includes 2 overlapping conditions. 1. Chronic bronchitis, defined clinically by productive cough on most days of the week, for at least 3 months, over 2 consecutive years. It's associated with mucus hypersecretion and airway inflammation. 2. Emphysema, a pathological diagnosis involving destruction of alveolar walls, resulting in loss of elastic recoil, hyperinflation, and increased risk of airway collapse during exhalation. Typical symptoms of COPD include chronic cough, sputum production, especially thick or purulent mucus, progressive breathlessness, worsened by exertion, chest tightness and fatigue. Wheezing is less prominent compared to asthma. Symptoms often appear after years of smoking, and the disease is frequently underdiagnosed until significant lung damage has occurred. The management of COPD is primarily symptomatic and preventive, aiming to relieve symptoms like dyspnea, slow disease progression, prevent exacerbations and hospitalizations, improve quality of life. As COPD is a chronic and progressive condition, the goal is not to reverse the disease, but to optimize lung function and limit further damage. Management is symptomatic to decrease symptoms and prevent complications as disease has progressive long-term decline in lung function. Pharmacological strategies in COPD include bronchodilator combinations, such as short-acting beta agonist plus long-acting beta agonist, are preferred over increasing the dose of a single agent. Inhaled corticosteroid are used selectively, especially in patients with frequent exacerbations. However, long-term inhaled corticosteroids use may increase the risk of pneumonia in COPD patients. Oral corticosteroids are not recommended for stable COPD due to their adverse effects. The combination of long-acting beta agonist and long-acting muscarinic antagonist shows superior improvement in lung function and symptoms compared to monotherapy. A helpful way to differentiate asthma from COPD is through key clinical features. This comparison is critical in guiding diagnosis and treatment choices, as the two diseases differ markedly in pathophysiology, prognosis, and response to therapy. Allergic rhinitis is an inflammatory condition of the nasal mucosa, triggered by allergen exposure. It is characterized by sneezing, itchy nose or eyes, watery nasal discharge, and nasal congestion. The condition occurs when inhaled allergens such as dust, pollen, or animal dander interact with immunoglobulin E-sensitized mast cells in the nasal mucosa. This interaction leads to degranulation and the release of inflammatory mediators like histamine and leukotrienes, resulting in the characteristic symptoms. Allergic rhinitis can be classified based on timing. Seasonal allergic rhinitis, also known as hay fever, typically occurs during specific pollen seasons. Perennial allergic rhinitis happens year-round, triggered by persistent allergens such as dust mites, cockroaches, or pet dander. Both types involve the same immunologic mechanisms and are treated using similar pharmacological strategies.
The management of allergic rhinitis focuses on symptom control and preventing exposure to known allergens.
First-line therapies include
1. Topical intranasal corticosteroids, highly effective for reducing inflammation and congestion. 2. Oral antihistamines, relieve sneezing, itching, and rhinorrhea.
Other options include oral and intranasal decongestants, leukotriene receptor antagonists, antimuscarinic agents, mast cell stabilizers. It's important to note that full symptom relief may take 1 to 2 weeks after starting therapy. Antihistamines are among the most commonly used treatments for allergic rhinitis. Common examples include
first-generation agents like diphenhydramine and chlorpheniramine, which are effective but cause sedation due to crossing the blood-brain barrier. Second-generation agents such as loratadine and fexofenadine, which are non-sedating and longer-acting.
These medications block H1 receptors, reducing the effects of histamine on target tissues. First-generation antihistamines, while effective, are often limited by anticholinergic side effects, including dry mouth and eyes, difficulty urinating, constipation.
These effects usually resolve within 7 to 10 days.
So second-generation antihistamines are better tolerated and are often preferred for long-term use. Nasal decongestants provide rapid relief by vasoconstricting dilated nasal arterioles, which reduces mucosal swelling and improves airflow. Examples include phenylephrine, a short-acting agent, oxymetazoline, longer-acting. These are available in aerosol forms with minimal systemic effects.
However, they should not be used for more than 3 consecutive days due to the risk of rebound congestion, also known as rhinitis medicamentosa. Intranasal corticosteroids are the most effective agents for managing allergic rhinitis.
Common examples include beclomethasone, budesonide, fluticasone, mometasone.
These sprays have minimal systemic absorption, and side effects are generally mild, such as nasal irritation, epistaxis, or rarely, nasal candidiasis. They're more effective than antihistamines in relieving nasal congestion, and their full effect may take several days to 2 weeks. Let's now turn our attention to cough, a common respiratory symptom. Cough is a protective reflex that clears the airways of mucus, irritants, and foreign particles. The mechanism involves sensory nerve endings in the airways, which send signals via the vagus nerve to the cough center in the medulla.
An irritant stimulates nerves that send a message to your brain.
The brain then tells muscles in your chest and abdomen to push air out of your lungs to force out the irritant. A coordinated response then activates muscles in the chest and abdomen, forcefully expelling air. The cough reflex arc consists of 3 major pathways. 1. Afferent limb, sensory fibers from the respiratory tract detect irritation and transmit signals via the vagus nerve to the brainstem. 2. Central pathway, located in the medulla oblongata, this cough center processes the signal. 3. Efferent limb, motor neurons send impulses to respiratory muscles, particularly the diaphragm and intercostals, to initiate the cough. Receptors involved include both mechanoreceptors and chemoreceptors, especially in the pharynx, larynx, and bronchi.
Cough can be classified based on its characteristics. Dry cough, non-productive. There is no mucus production, and it's often caused by irritation or allergy. It requires antitussives to suppress the reflex. Wet cough, productive. This involves mucus or phlegm, and treatment aims to clear secretions using expectorants or mucolytics. Understanding the type of cough is critical to choosing the correct treatment.
For productive cough, 2 main drug classes are used. 1. Mucolytics. These dissolve thick mucus by breaking disulfide bonds within secretions.
Examples include N-acetylcysteine, ambroxol, bromohexine.
2. Expectorants. These increase the volume or hydration of secretions, making them easier to expel. Stimulant expectorants, like guaifenesin, act directly on bronchial secretory cells. Sedative expectorants, such as ipecacuanha or ammonium chloride, stimulate gastric reflexes to enhance secretion.
Now let's discuss dry cough, also known as non-productive cough. This type of cough lacks mucus production and often results from airway irritation, viral infection, or postnasal drip. Treatment focuses on suppressing the cough reflex using antitussives. Antitussives are divided into two categories. Central acting agents, which inhibit the cough center in the medulla oblongata.
Peripheral acting agents, which reduce the sensitivity of cough receptors in the airways. Centrally acting antitussives include both narcotic and non-narcotic medications. Narcotic agents like morphine and codeine are potent cough suppressants but carry a risk of sedation, constipation, and addiction.
Morphine is reserved for severe, intractable cough, especially in terminal illness. Non-narcotic agents include dextromethorphan, an opioid derivative without addictive potential. Diphenhydramine, which combines antitussive action with antihistaminic effects.
These are widely used for mild to moderate dry cough, especially in upper respiratory tract infections.
Peripheral antitussives agents include pharyngeal demulcents, like lozenges and syrups, which form a soothing coating over the inflamed mucosa. Agents with local anesthetic action, such as menthol or tincture of benzoin, which numb the cough receptors and reduce sensitivity. Steam inhalation, which hydrates and soothes dry, irritated airways, offering symptomatic relief. These treatments are particularly helpful in throat irritation or post-infectious dry cough. Thank you for watching.
If you enjoyed the video, please like and subscribe for more pharmacology insights.
Hit the bell to stay updated. Keep learning.